Tracy echoed these sentiments and explained that patients need to do what's best for them and that they should have conversations with their doctor about the goals of their treatment. She was one of those patients who needed to weigh the risks and benefits. CDK4/6 inhibitors were not yet available to patients with early estrogen receptor positive breast cancer when Tracy was diagnosed. But because she had some risk factors for recurrence, she decided to ask her doctor about the CDK4/6 inhibitor abemaciclib when she saw the results of the Monarch E trial.
There's a very long, contingency line of like where people fall on, I'm willing to go for this and I'm not willing to go past this in terms of my treatment. And so I'm one of the, I'll do literally just about anything. I was so young when diagnosed. I have a kid, I would rather live to a ripe old age and die of something else other than breast cancer if possible. And so for me, when I read the data, I brought it to my oncologist and I was like, hey, there's these drugs, there's CDK4/6 inhibitors. And in one of the trials, a high Ki-67 was one of the inclusion criteria, and that they saw a benefit for these things. And maybe that's me. Maybe I didn't have chemo, but I still had an intermediate oncotype and this high Ki-67. So maybe this is a way that we can reduce my risk given those things. And that was a totally new thing, that didn't exist at the moment I was diagnosed now 3 years ago. So that was pretty cool. But I really think that just asking that question at any point along treatment, right? Whether early stage, even metastatic, like what are your priorities, right? Because maybe it's not what your provider thinks is your priority. And it's really important, I think, to know that.
Ribociclib is not yet FDA approved for early estrogen receptor positive breast cancer, and we're still waiting for more data. We asked Dr. Bardia what new questions the results of the Natalie trial raises for doctors.
I think there are three important questions that the Natalie trial has raised. The first one is, how would the results look like with additional follow-up with 3 years of ribociclib use, and what impact would that have on overall survival for a patient with ER-positive breast cancer? The second question is, are aromatase inhibitors the best backbone with the use of CDK4/6 inhibitor? Given the interest of oral SERDs, elacestrant, other oral SERDs, can those agents be used with ribociclib to further improve the outcomes for patients with ER-positive breast cancer? And the third is biomarkers. Do all patients need CDK4/6 inhibitor? Can we identify a subgroup that would derive more benefit, or vice versa, a subgroup that would not derive benefit? So we need more translational research to understand biomarkers to further fine-tune the benefits seen with ribociclib.
Dr. Tolaney agreed that longer follow-up and treatment personalization is crucial for not only the Natalie trial, but for all clinical trials that are looking for new treatments for early estrogen receptor positive breast cancer.
So I think when we're trying to develop treatments in hormone receptor positive disease, it's definitely an exciting space, but it can be tricky. And one of the reasons I think it has been challenging to shift the field is, one, thankfully, most patients actually do really well who have hormone receptor positive breast cancer. We, in fact, cure the vast majority of patients who have ER positive disease. And so that's, been fabulous. I think the challenge has been picking out those patients who are at higher risk of recurrence. And so can we figure out from the biology of the cancers which patients are those patients who are going to have their cancer potentially recur, and how can we prevent that? And so I think that's one of the areas that we've been really working hard towards, is trying to identify biomarkers to help us figure out which patients need additional treatments. I think the other challenge is that sometimes hormone receptor positive breast cancers can lay dormant for many years. And so sometimes what we see is that they actually can come back 10, 15, 20 years later, which is very different from other subtypes of breast cancer, which can recur much quicker. And so to study this takes a long time. And so that's not something we get quick answers to, which again makes it a little bit more challenging. We can't quickly understand which drugs are having benefit versus not, without following patients for many years. And so again, I think that's one of the challenges with getting new drugs approved, is it does take us time in hormone receptor positive disease to really see which drugs are having impact.